Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live weekly webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box and be visible to all of the attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We're grateful to have the opportunity to be and live in this territory. Today, we're delighted to welcome Children's Healthcare Canada member Alberta Children's Hospital and bring you A Path to Equity, how care coordination is helping children with medical complexity and social challenges. As mentioned in the intro video, please type your questions into the question box at any time. I'll prompt you via the chat as well, and I'll pose the questions to our panel at the end of the session. Now I'd like to introduce our speakers today. Gina Lachuk is a project manager with the Neurodevelopmental Disorders Integrated Brain Initiative at Alberta Children's Hospital. Her role incorporates engagement, evaluation, and continuous learning to demonstrate care coordination on families of children with complex medical, developmental, behavioral, and social needs. Meredith Yahomas is a care coordinator with the Neurodevelopmental Disorders Integrated Brain Health Initiative, where she supports families of complex children with attention deficit and hyperactivity disorder and or autism spectrum disorder to address interrelated medical, social, developmental, behavioral, educational, and financial needs in an effort to achieve optimal health and wellness outcomes. And Genevieve Curry is a parent advocate, nurse, researcher, and mother of 2 children with neurodevelopmental disorders. She's a tenured associate professor at the School of Nursing at Mount Royal University and a PhD student in the Faculty of Nursing at the University of Calgary. It's my pleasure to pass the mic to Gina.
Good morning. Thank you. I'm just going to grab our slides quickly. Okay, thank you. So while I talk to you a little bit about our conflict of interests or non-conflict of interests, I just wanted to acknowledge some of these very important funding partners that work with our project. So we as a panel do not have any conflicts of interest. We do not have any relative financial or non-financial partnerships to disclose. So we will be talking today about the NDD Care Coordination Project, but not so much necessarily about the structure of the project, but we want to talk more around impacts and some of the things that we're learning so far. So we do know that children and families with complex needs often experience a persistent lack of coordination across child service sectors and face many barriers to accessing care and services. This eco-map here is a visual snapshot of the people and supports that surround G, who's at the middle there, who's a child with complex care needs. What we're looking at here is the sheer number of bubbles that need to be coordinated in order for this child to have optimal outcomes. And when we think about the fact that a lot of that largely falls to families, it's quite daunting, and it's really easy to see how care can become quickly fragmented and how parents can become stressed and overwhelmed. So when we started looking at a population that we wanted to test this care coordination project with, we acknowledged that most families, most children function very well with the universal supports that are available within health, and sometimes touching into those specialized services and sometimes into that episodic urgent care. But we wanted to focus really on those kids with that live mostly in that complex care area, because we recognize that they kind of move up and down this triangle, and that as they move up, that there are increasing levels of biomedical, psychosocial, and systemic complexities that can really affect their impacts. So some of those medical complexities could be, a new or additional diagnosis, an increase in severity of symptoms, surgeries. There could be a major surgery that could be one of those episodic urgent care times where they may need some extra support. Caregivers are exhausted and they're isolated, and especially now during COVID-19, we're seeing some really different types of exhaustion in caregivers. There's can be an increase in severity of behavioral problems or risk behaviors. Some of the systemic issues we see are services that are needed that can't be accessed, or even more frustrating, don't even exist. There are cultural or language barriers with a lot of families that require a little bit more assistance in navigating the health system as well. So these are kind of the overarching outcomes that we had decided that we would want to focus on for this particular project. And so for this project, care coordination is a time-limited activity that's intended to meet identified needs and goals. And so the care coordinators work with care teams and with families to kind of come up with a common set of goals that will help them meet the needs of the family within the time period of care coordination. So some of the preliminary data and emerging themes that we're seeing from qualitative interview and from some of our quantitative data show that we are having an impact on families and care teams in these areas. And so that's really exciting to see. With the rest of the time today, we're going to introduce you to some of our families. And so first I'll turn it over to Meredith, who's going to talk about a case review. And she'll examine the challenging journey of this family as they worked with their respective care teams to overcome some of these systemic barriers, looked at some stigma that the family has faced and some possible breakdown in the family. So this will shed light on some of these chronic issues that families face, such as being labeled as a challenging or non-compliant family, the impact on parent stress and mental health, and the financial strains, excuse me, that can also occur. Possible inequitable access to health and community services, burnout of providers and parents, and moral distress in deciding the right things to do. So again, I will turn this over to Meredith, and she will share with you this case study. Thanks, Meredith.
Thank you, Gina. So I wanted to talk about one of the first families that I worked with when I started as a care coordinator with this project. This was a 16-year-old boy and his father. The child was born with medical and developmental challenges. He was diagnosed with epilepsy at a young age with seizures that were poorly controlled by medication. He had global developmental delays diagnosed as a preschooler, and ADHD and intellectual disabilities diagnosed during the elementary school years. A history of exposure to trauma early in life contributed to attachment and mental health issues, and there had been intermittent involvement with child services. Nothing ever long-lasting, which can have its pros and cons depending from your perspective. At the time of my involvement, neurosurgery was being explored to treat the epilepsy, and this resulted in multiple medical appointments, lots of tests, hospital stays. This boy, he was a typical teenager in lots of ways. He wanted his independence, wanted to have friends, was going through puberty, wanted a girlfriend. He liked cars, camping, but he really had limited insight into his capacity. He had difficulty problem solving and was described by the adults in his life as socially immature. Education-wise, he bounced from school to school and attended various specialized placements that were trying to address behavioral, developmental, and or mental health needs. He'd recently started high school, and in this environment with less structure and increased social demands, his behavior was becoming increasingly aggressive and inappropriate, and that resulted in school suspensions and him being at home or in the community left to his own devices, definitely vulnerable and at risk. His only recreational activity was hockey, but he was going to have to miss the season due to this impending neurosurgery. And when I started with this family, the boy had undiagnosed ASD. So this would be a case, I think, of pretty significant diagnostic overshadowing. His father always felt that there was something else going on, but was told that the epilepsy or the ADHD or the intellectual disability could be attributed to some of these differences. Due to its severity, the epilepsy was a primary medical focus. And with Dad's other concerns being minimized, this resulted in a lack of trust in the care team, the father not feeling heard, and the son was picking up on the tension between the two. So the father, when I met him, he came across as irritated, frustrated, and angry about everything. He was paying for medication that didn't seem to be working. He was trying to hold on to a job in an economic downturn while needing to take time off to get his son to his multiple appointments and assessments and manage the expectation of being bedside during the multiple hospital stays. As I got to know him, it was very apparent that the irritation, frustration, and anger were a result of all the stress he was under. He was worried about how violent and injurious his son's nightly seizures were becoming. He had difficulty coping with medical decisions, including analyzing the risks, benefits, consequences of neurosurgery, and this was really a terrifying and incomprehensible procedure for him. He was trying to deal with medication management issues with a violent, non-compliant teenager, and down the road of multiple mental health inpatient admissions. And this father also worried about what would happen to his son if something happened to him. He didn't know how to manage his stress in a healthy way. He didn't have any natural supports. His one social outlet was through his son's hockey team and, through the other parents there. And as I mentioned, this was taken away. And he was uncomfortable seeking out support from others. Often it's saying he didn't need to focus on his stress, that his son's needs were paramount. And if his son was okay, then he would be okay. Although eligible, he was not accessing the community supports that, and due to various barriers. So pride being one of them, not wanting to ask for help. As well, there were a few viable community resources, especially to manage a boy who's becoming increasingly aggressive and a growing risk to himself and others. And another barrier for this dad was just the onerous paperwork and procedures that were in place for him to complete, to be able to access funding sources and services. So, for close to the 16 years, this father had been tirelessly working within the health, education, and social systems to raise his son to the best of his abilities. And he was exhausted and expressed his frustration with the health system and its providers. In terms of the care team, so similar to the eco map that Gina showed, there were over 40 professionals across health, education, and community that were involved with this patient and family during my time with them. These were dedicated care team members struggling to meet the needs of the complex patient and family, and were often on the receiving end of Dad's frustration and desperation, and felt that they were doing everything within their scope to meet this family's needs, but also recognized that more was definitely needed. In terms of, so this case sort of highlights many of the challenges that the families we work with face, highlights the health complexity, so multiple diagnoses and trying to understand how they're interrelated or the cumulative impact of the diagnoses on all aspects of the child's life. We hear about the significant burden of care placed on the family's shoulders, having to constantly advocate for themselves and their child while still managing everyday, day-to-day life. Parents often working with each system independently of one another and expected to be the case manager or the go-between for each system. And some parents, for whatever reason, are not equipped for this. And as a result, things get missed or overlooked. They can't follow through with recommendations or take the necessary steps to get the supports or services that their child needs. And it is definitely not because they don't want the services or the support. Parental capacity definitely plays a role in the challenges families face. So as I mentioned, the paperwork and the forms and medication, making complex medical decisions. And as we get to know these families who have been under such stress for so long, there's the parental mental health piece that often gets overlooked or not known how to address. And also, in my case as well, the child's capacity, so his cognitive profile and the parent-child relationship, and how that that played upon this case can also be an important factor. I'm just going to ask Genevieve, from a parent's perspective, if to add a little bit to some of those challenges for families.
Good morning. Thank you, Meredith. So I'm going to respond as a parent to the case study, but also as a parent researcher who did research with 15 parents with children with neurodevelopmental disorders. And so certainly from my research working with families, I would say that the impact on the family is substantial. Excuse me. And that our present system of offering compartmentalized care models, which are really only designed for periodic health incidents, not for complex disease trajectories, such as in this family that Meredith has showed you. Certainly with unmet care needs, parents experience pervasive demands. And some of those demands are related to the medical complexity of the child. So there's multiple issues, multiple medications to juggle, multiple body systems involved in trying to determine care and intervention, and lots of unknown challenges and issues that continue to come up and go down, as Gina mentioned earlier. This leads to ongoing stress and responsibility for caregivers who are responsible and accountable 24/7 for their children's welfare. Researchers are now calling this responsibility with frequent crises and providing medical care to their children in the home and in communities as crisis and trauma. So no one truly knows the journey and path, I would say as a parent myself, no one truly knows that and how much coordination and energy it requires when your child is so complex. Certainly this complexity leads to substantial stress on the whole family, and particularly on the siblings, if there's any siblings in the family. And often this is not considered or remembered that everyone is affected, in particular the siblings that are living at home. Within my research study, parents expressed frustration because of the systemic barriers that they were dealing with episodic care models and lack of coordination of services across the medical and school and government systems. And most medical care and government care is managed through silos. So the systems do not talk to each other and do not connect, and certainly often don't provide an overall plan for the child. And providers treat the child within a body system. So you take your child to the GI clinic or the endocrine clinic or the respiratory clinic, but those clinics don't talk to each other and look at the impacts of the medication and the interventions. Certainly in my case, an overarching issue was that the behavioral issues were affecting everything and nobody was addressing those. So it's a large navigation and coordination role for families. Parents have described the current system of healthcare with children accessing subspecialty experts with little focus on the overall multi-system disease manifestation as extremely stressful and isolating. And there's generally a lack of discussion or coordination across systems or sectors. As I mentioned, the system can include the school, disability services, and health. So overall, parents within my research have summarized a sense of feeling diminished and disregarded by the medical system and those providing care, and generally extremely overwhelmed with the day-to-day management of their children. Meredith, I'll turn it back to you.
Okay, thanks, Genevieve. Okay, and I will now touch on a little bit of the care team challenges. So as you could tell from the case that I discussed, there were a lot of psychosocial factors that were impacting this particular family and their care. And often care providers maybe don't have the experience or the expertise or the time or the resources to address some of these factors. And as well, there's lots of stigma associated with some of those factors, and it can take a lot of time to get that complete picture of what is happening for this family, for the parent to feel and trust and ability to open up about some of those other issues that are going on for them. Complex care also takes, for anyone who's in it, knows that it takes a lot of time, and the health system isn't always set up to afford that time to providers. They're often having to make decisions in isolation from other services and clinics. Caseload can be definitely a part of that. So, for example, a community pediatrician may see 15 kids in a day, trying to connect the dots for all of them, sometimes with a nurse or a social work support, maybe, but often without that team around them. And similarly, a hospital or a subspecialty clinic may have 500 patients on their caseloads, and again, complex patients with multiple diagnoses. So a provider may have expertise in, for example, epilepsy and neurosurgery, but do they also have expertise in autism? Maybe. What about with ADHD, intellectual disability, parental mental health? All of the above, right? So it can definitely be hard for these practitioners trying to get that whole picture and work within that complex picture. And then physicians have other responsibilities: rounds, checking on labs, training residents, attending meetings, conferences, research. From what I have heard from some, that it's basically they're in clinic only about a third of the time. Although not a factor as much in my case presentation, but when there's cultural language barriers, it adds on another layer. I find through health, we're able to access interpretation often, but with education or in the community, often that isn't a resource that they're able to access or access consistently for those families. So, the providers dedicated regularly are working out of scope to arrange for the supports, but they do also have their hands tied in lots of ways. And I think that these, as Gina mentioned too, these families are stressed, emotionally dysregulated parents, and they become perceived as rude or non-compliant, as opposed to just stressed and exhausted. And with providers who are having are confronted with some of those issues and complaints, it can definitely lead to that provider burnout. And then in terms of larger systems, some of those challenges there is definitely a high demand. There seems to be more complex patients that are needing support and services, and these are very costly. We also find that improved communication across sectors is a commonly identified need. One thing can be there's a mismatch with school hours, clinic hours, parent work hours, so trying to find time to do the complex work. Each sector will have its own set of consent forms that need to be completed to be able to collaborate on behalf of a patient or family. Often there's no great way no shared way of communicating across sectors. So, for example, the community sector does not have easy access to health records. Pediatricians at times not having access to some of the hospital clinic information. Schools, needing medical information, but needing to go through parents. And some of those can definitely create challenges for within the system. Although, happy to say that there's work currently underway in Alberta to try and improve this. And then with complex patients, often new teams or services have intermittent involvement. So providers can change, or they'll come together based on an admission, and that need to trust that each member knows what he or she's doing, what their role is, that they're up to speed and following through on those recommendations. The other thing, it can be easy to identify what a family needs, but often there are long wait lists for services, and the service might not even be available in a community, or it may not be affordable for a family. So we definitely see this with children and youth with severe behavioral challenges. There's difficulty finding and keeping staff who can manage these severe behaviors. It's a unique skill set that's required, and not a lot of community providers have that skill set, or they maybe will charge more than is covered through some of the disability-related programs that can help subsidize the costs of those for families. And then COVID on top of all of that has further limited options for sure. And through working across systems, it's also become apparent that it's really hard for us to shift to more preventative care. We're really good at putting fires out, but this can lead to more costly care. There are times when families, feel like they have to exhaust all options before being able to access what works. These complex cases require creativity, and it's imperative to have the key decision makers at the table who are in support of doing things a little bit differently or outside of the box for these patients. And sometimes it can take multiple failures to kind of get to that point, unfortunately. I'm going to in summary, as a way of sort of providing more equitable care and access to services, we have implemented a care coordination model at the Alberta Children's Hospital for complex patients with neurodevelopmental disorder and a medical complexity. So I'll spend a few minutes just reviewing our model and highlighting some of the components of care coordination that may occur. This model is adapted out of a care coordination model out of Boston Children's Hospital. And I'll just kind of walk you through a little bit of this. So starting at number one, that's where we have our identification and engagement. So our referrals will come in from subspecialty clinics, community pediatricians, or allied health providers. And once a referral has been accepted, we conduct an extensive child and family needs assessment with the parents. So trying to get a sense of the family's journey, who's broadly involved in their care team across the systems, and whether there are any gaps in services or unmet needs. Upon referral, we have the care team identify their priorities or markers of care coordination success in their view. And then with the family, we aim to balance the care team's priorities and the family's priorities and set some goals. And it's also at this time where we ensure we have the consent to reach out across sectors, work within schools, with community providers, government support agencies, etc. And then that's where we then move into the active care coordination activities. And so once we have a plan, we start to address the goals with the family and with the care team. And so some of the areas of focus can be, as I mentioned, improving communication and information sharing across services. So ensuring that critical health information gets into education plans, for example. For some families, it's really about optimally coordinating the services and visits. So some families feel like they are at the Children's Hospital all the time. And so we look at trying to see if there's capacity for us to reduce multiple trips to the hospital, to avoid missed days of school or work. And then also when families have so many appointments, they can miss appointments or have conflicting appointments. So that can sometimes be a challenge that we can help work with the clinics and the families to address. Also, a big role is supporting and facilitating health transitions. So definitely hear that families feel like they have to tell their story over and over again. And so what we can try and do is help connect with a new community provider or a new health provider or school. This can also sometimes involve what we call kind of a warm handoff, where we will support the family in the moment during a new appointment or initial visit, and help them make sure that things don't get missed. Also, we can anticipate some of the information that's going to be required for a new provider and can connect with them beforehand to help fill in the gaps and increase the efficiency of that appointment. We also help link and connect children and families with services and supports. So helping with, applications for an agency that might provide respite and helping to link key members from different sectors. So having a more direct connection between educational supports and the care team or social supports with health, so that these systems can communicate with one another without always having to go through the parent. Some of it can help families with the daunting task of filling out forms and providing strategies to help them organize some of their child's medical information, for example, so that going forward that some of those tasks are a bit more manageable and they feel they have more skills and confidence to carry on with that work. We'll put in referrals for agencies that help with access to financial supports, basic needs. And in the interim, for some of those agencies that have wait lists, we might start the process with the family while they're on the wait list. And one of the other benefits of care coordination, I think, is that because we're time limited, we do have the capacity to check in with families and follow up on what's been completed, how it's going, if there's steps that need to be broken down, how we can share the workload of what needs to be done for them to access supports and resources for their child. And once we have that, I think, improvements in some of those broader areas, then we really try to focus more on the helping families with the advocacy skills, helping them prepare for appointments so that we don't maybe have to go with them, or providing supportive phone calls afterwards, helping to build self-management skills, connecting them to agencies that really specialize in helping with self-advocacy skills and can help work with the families more longer term. And then just within the moment, modeling, how questions to ask providers, how to manage those appointments better, and for the families to feel more confident. And then another sort of offset to that is also team empowerment. I think, a lot of our work can involve having large regular case conferences, and at first the care coordinator may take on that responsibility, but look to trying to transition that so that maybe down the road it's the school that coordinates that and has that ability to include the members from the other sectors. And then we move into sort of number 4, where kind of just ongoing monitoring of goal attainment, how the family is functioning, looking at a transition plan, whether they can resume just the regular care that's being provided through the clinics that they're already connected to. If there's something else that needs to be addressed or modified within the care coordination goal, we might be able to address some of those things. But really the goal is to get the family hopefully connected to some good point people in the community and have already established a good network of supports within the other systems when we step out of the picture. We're going to show a short video just that looks at care coordination, and then we'll highlight some of the impacts, and then I'll come back and focus a little bit more on some of those as well.
In the same breath as one improves outcomes, one reduces costs to the system, which is very, very important in Alberta.
Before they came into play, trying to get the same information to 4 different doctors or plus the schools. I feel like with this care coordination team that is here, everybody's on the same page.
I think one of our biggest successes in this project and this program is just having that time to really get in and understand what's going on, and then share that out and try and make a difference for the healthcare system as well. So that would be community pediatricians' offices, any specialty clinic across the street at the children's, and as well the government-funded FSCD and schools.
I feel these families come back to be more empowered. They realize that they've learned some skills to advocate better for their children. So I think they're much more comfortable and confident to follow through on the suggestions. They are quite comfortable accessing the care coordinator. I've felt like all these families have really benefited and been quite happy with what they've received. And so I feel much more confident when I make a recommendation that they're going to follow through. And we are seeing actually better rates of actually showing up for appointments in our office, and that in itself is a testament.
It allows me to really focus on my area, but work in a multidisciplinary team so that my families can access all the different clinics or resources that they need to, and I know that it's taken care of. It's been very, very helpful for me. It's reduced my appointment times. It's allowed them to be more efficient. It's been fabulous. I can't say enough about it. It's a fabulous program.
It provided with me another way of doing things, like the team approach to care and with a complex child, and I'm sure it would be the intention of physicians and providers to do that more often if they weren't working in silos, but it gave me hope that there's a different way of caring for children and families, a different model of care.
Okay, so as mentioned in that video, we're definitely finding that this model of care coordination and the support that's being provided to the families and the care team is showing to improve access to services, community services, health services. We're seeing reduced in emergency department visits, acute care visits, and as the pediatricians in that appointment mentioned, or in the video mentioned, that less less missed appointments. The subspecialty hospital clinics are reporting the same thing, and there are times where we're able to, because of our involvement and having that big picture of the family, pick up on some of the things that are being missed, or potentially good duplication of services, those kinds of things. We definitely hear from families and care teams that there's better communication across the sectors. And as, again, reduced clinic time, being able to focus on, we often say care coordination fills in sort of those spaces in between appointments or, meeting renewals. We have that information that has what's been going on in between those spaces and can share that and then can help the appointments move forward as intended and definitely get more done within that time frame. And then I think very importantly, we find that there's a decrease in parental stress that's reported. And at this point, I'm going to turn it over to Genevieve to talk a little bit more about those the impacts and that parental component for care coordination.
Thank you, Meredith. So the word cloud you see before you is words that came out of the qualitative interviews that came from the care coordination project team. And so obviously the ones that you see the most are the most frequent words. And so that can really highlight the impact of care coordination and what it's done for families. I'm just going to highlight what it's done for my family since we were involved with care coordination. So when we became involved, my son has a rare neurodevelopmental disorder as well as having autism. And then during the course of my involvement with the project, my other son was also diagnosed with a neurodevelopmental disorder. And I would really say that the care coordination project was a lifeline for myself and my family in dealing with ongoing complexity and issues. And finally, there was somebody who would listen to us and talk to us and help us get through these multiple systems. So certainly we were navigating the school system, medical specialty clinics, disability services. Those teams were not talking to each other, as Meredith has showed that it's very difficult for them to talk to each other. And so there was different care plans and different issues within each of the systems, and nobody was working it out. And it was really up to myself as the mother, as the primary caregiver, to try and figure it out. And so as you had seen also from the care map that Gina showed, I did one myself for my family, and there were at least 32 providers that we were trying to coordinate my son to see regularly. And the absolutely powerful thing was that my care coordinator was able to have a meeting at the Children's Hospital with so many of those providers in the room, including myself and my husband and the care coordinator who was facilitating the meeting. And there was the community pediatrician who's been, again, just a wonderful support for us, but he came to that meeting. There were people from my son's school. There were people from disability services. We had a medical expert helping us who was more familiar with my son's disorder, and she was taking questions. And what was so amazing was that people could dialogue with each other and say, oh, I didn't know he was on that medication, or have you thought about trying this instead? Or, oh, well, I didn't know that was going on with him or at the school. And that we came out of that with a much stronger care plan that continued over the course of several meetings. And that for me was just a highlight of being involved in the project. And my care coordinator certainly spoke up for us at lots of case coordination meetings with medical appointments, disability appointments, school appointments. Sometimes we would be given vague answers, or there were certainly large gaps in care that she knew we were still trying to address, and she would speak up for us at those meetings. She certainly listened to my ongoing challenges and suggested other resources and programs. And in our case, behavioral intervention and behavioral support was a big gap. And we weren't able to hold on to respite and aids because of my son's behaviors. And so she was able to help us to find someone who understood his behaviors and his disorder. And then we could provide input into that care, as could the school, disability services, and the medical team. The other remarkable thing for us is that she would attend to services for the whole family, including services for my other son, who at the time didn't have a diagnosis, but as I mentioned, he eventually did. But she also provided services to us, such as SIB Shops, which is a really wonderful program in Calgary for siblings. And she just had him in her mind, as I've had him in my mind for so long, about worrying about, is he being lost in this process, because we spend so much time and attention on his brother. And certainly overall, she was someone who listened. And as Meredith had mentioned, you feel as a parent, you're telling your story over and over again, and you wonder, does anyone read the notes? Does anybody pay attention to what I told at the last visit? Does anybody read the assessment sheet when you go into a specialty clinic and they ask you, what's the most important thing you want us to address today? And then that seems to be forgotten. She would be there and listen and advocate, and certainly made me feel that I did have a very complex child, and that I was right to be overwhelmed and stressed, and that there was another way forward. And the other way forward was trying to navigate through such a complex system. So certainly care coordination, like I said, was a lifeline for us, and it just continues to be a wonderful project. Thank you. So I'm just going to show you then just some thank yous, and there's our contact information. So Meredith, Gina, and myself, and then the Care Coordination Project email. And I believe now we have some time for questions.
Thank you all. There are a number of questions and comments, so I'll get started right away. Our colleague Anne, who's here visiting us virtually from Ireland, says it sounds like they have the same issues no matter where we live. It's uncoordinated and disjointed. Repeat storytelling from parents is a thing too. The lack of care coordination appears to be a common denominator. So at least in Ireland, it's very similar to Canada. And does ask, are these neurodevelopmental disorders ones that are caused by copy number variants?
Our project primarily focuses on neurodevelopmental disorders of autism and or ADHD, although the children may have other diagnoses as well. And then in terms of the medical complexity component, we also take that to be quite broad in the sense that they are followed by a subspecialty clinic, either at the Children's Hospital or within mental health, or here we have Child Development Services, which is a part of the hospital, but more for developmental issues. So that is the population that we're working with primarily through our project.
And do they all get a genetic test in your program?
I think often kids with autism will have genetic testing, but really we're not associated with a physician or a clinic. So there's two care coordinators, myself and another care coordinator, and then we work within the health team that is already established. And so for sure that may be a recommendation or may already be something that's been completed, but not specifically.
Okay, thank you. From Michelle, does your intake questionnaire consider the social determinants of health and systemic inequalities or inequities that may be faced by a family, like income, racism, issues around gender, parent mental health, those sorts of things? And given the impact of stigma on access to care, wondering if and how this is factored in.
Yes, we do ask some of those questions, not necessarily specifically broken down in that way, but definitely look at social determinants of health, and often information will be provided by the referral source on that. What we also find, though, is sometimes it's not necessarily known or it hasn't been completely disclosed, and then through the course of our involvement, more of those pieces will come up, and that's definitely something that we, as care coordinators, have had to address or advocate, support. Look at those factors for sure. I think our caseloads are pretty unique. Each case, each family that we work with has a unique set of circumstances and gaps or unmet needs, and so we definitely do our best to look at the whole picture and find out what, again, family priorities are, and how we can address all of those.
Wonderful.
Hopefully that answers that question.
There's a number of folks, Ali included, and Nyok, who would like to know if you're servicing families from anywhere in Alberta, in particular rural communities, or is it just in Calgary that your service catchment area is?
I'm going to grab this one, Meredith.
Oh, sure. Okay.
We're primarily servicing the Calgary zone. We have done some rural in and around the Calgary zone. Primarily, the reason that was decided when the project started was because that was the area of expertise of the team that was going to be working. So in order to provide the best service to families, they thought that it was probably best to keep it to the zone where the resources were best known.
And is this ready for spread and scale then, or are you still collecting data to help you better understand your service and its impacts?
Probably both. I think that we're definitely looking at sustainability and scale and spread across the Children's Hospital. We've been more targeted. We've been focused on word of mouth and targeted referrals where people hear about us and get to know our service, but we would like to move towards more scale and spread so that we're more well known across the site, and so that we can hopefully spread some of these skills and some of the principles around care coordination broadly, I guess, across the site and the zone. And then, yeah, I guess the next step after that would be how do then we scale and spread across the province.
Wonderful. And sort of building on that, Anne has asked, are there any international collaborative research initiatives that you know of in this area?
It's too bad. Our manager, Nadine, is probably the best person to answer that question. We may be able to get back to you with that. It's collaborative initiatives, I'm not certain. We do have some international partners. We've had some, the care coordination model that we're using came out of Boston Children's. We've worked with organizations across Canada, BC Children's and Ontario. And there are some other organizations in the States that are doing some work with complex populations that are not necessarily pediatric that we've touched base with. So I think that there have not necessarily been those collaborative efforts that we've seen internationally. I know that there is the pediatric echo that's getting going now for some complex care, and I think that's really exciting work.
Oh, wonderful. Jacinda is wondering about the use of scoring tools to help identify respite hours for families with complex medical needs. Is that something that you can address?
I'm not familiar with that. No, I'm
okay.
sure if there's more information. So there's, and maybe that's just not how in Alberta.
Sure.
We look at that. Often families will access supports and services through, there's family support for children with disabilities, and based on their need, respite is often a service that that government agency is looking to help support sort of the exceptional costs related to parenting and raising a child with a disability. And so often funding for respite can be provided through that agency. So usually when we work with families, they may already have certain number of respite hours that they're able to access, and then we look at trying to help them use those hours, being able to use those dollars.
Great, thank you. And Jacinda, if you wanted to, Jacinda has commented, we're looking at developing the scoring tool. I'm wondering if anyone from areas outside of Alberta has such a tool. So if folks do, please let her know in the chat box. Tessa has asked, do you frequently attend subspecialty visits like school meetings, etc.? Are they in person or virtual? And do you do a lot of the work pre and post appointments, or is that the responsibility of others on this child's care team?
We definitely do attend those meetings. Pre-COVID, we would, their meetings were more in person for sure. I do find that since we've all been on Zoom, that those meetings are a lot easier to schedule and have better attendance at. So again, maybe one of the positive pieces of from all of this. So yes, we will. We can attend subspecialty clinic appointments and go into the schools. Sorry, the second part of that question, Paula.
Oh, let me go back. Let's see.
Sorry.
That's okay. I'm just going back. Do you do a lot of the pre and post appointments?
Yeah, again, depending, I think we do in a sense. Often I'll collect some information before, let's say it is going to be a case conference. And if that's something that I'm going to be facilitating, then it would be, usually I have some of that information of what's been going on in between, or, what's been going on in the different sectors. So sometimes it is kind of getting that information together and also following up afterwards with sort of what the takeaways are and what everyone's agreed to do and carry forward from some of those meetings or appointments. And sometimes it's working with the parent and kind of coaching them through that, finding out what their questions are, giving them, idea. Well, let's write those questions down so that you can make sure you don't forget to ask any of those things that you've been wondering about. Or so some of the work can look like that sometimes as well.
So some self-advocacy and anticipatory guidance support.
Yeah, I mean, that's definitely our goal. I find initially there's a lot of, we can't hold hands. That's sort of the messaging that we get. But I find with some of these families, when we start off, unless we do that, unless we help support them to get them into a place where they can go on their own, I don't find that we can be as successful or we can get the outcomes that we need. And so while we can't be, I know there was a question about length of involvement. Our maximum is kind of a year is what we say, although some families need less care coordination and some definitely at that year point we feel, there's more work that we can do and needs to be done. But definitely our goal is to step back and have the connections and the parents, newly acquire confidence or skills or abilities, be able to carry them through. Because the neurodevelopmental disorder is not going to go away, and the child's needs and the complexity is not going to go away. But if we can provide them with, tools in their toolkit and already a team that's better able to support them, then it makes it easier for us to step out.
Can I just add to that as well, Paula?
Oh, go ahead.
I just wanted to add that I do most of the qualitative interviewing with our families when they leave our program, and I hear a lot of really specific examples of exactly what Meredith was saying in terms of skill building. So our care coordinators going to appointments and helping with some of that pre-work and post-work between appointments. What I hear from families down the road is how that modeling and how learning how to do that has helped them be able to continue more efficient appointments in the future, or know where to seek out resources if things are starting to go poorly. Or in one case, a mom told me that she was involved with another agency after being discharged from care coordination, and she's been asking that agency to step back a little bit and allow her to do things while she still has their support and before she's discharged from that program. So some really great concrete examples of how we're helping families build skills and build resiliency for the future. Because as you said, Meredith, the NDD, the diagnoses aren't going away.
Any advice for parents who've struggled to get physicians or home care willing to sit down with the team?
Yeah, I know that can be a challenge for sure. I think it's, and Genevieve, maybe you might have some tools for that too, but I think it is to find, if it's your community pediatrician that is that point person or that quarterback, to be able to try and help facilitate that. I think it can definitely be hard, but definitely you need to be making those requests and advocating for that. Genevieve?
And what I would add is that the care coordinator helped us to have that. She provided that advocacy, and people seem to be more accountable to her, because I'd been trying for a long time to have a team get together and talk about the care for my son, and yet people were so busy and it wasn't a priority for them. And so I think having somebody from the outside who could see the big picture and said, no, if you could all get together and talk and chat, then you would save a lot of time and effort and actually resources from doing things independently of each other. So in our case, people were not talking to each other. And so I needed that outside person to advocate for myself. And sometimes in the last question, the parent has some of those skills, but people are not willing to engage in that way because it's a new way of working together. And I think the care coordinator model is just that. It shows a different way of working together that's so powerful. So sometimes you need somebody in your corner to try and get the people to come to the table.
You mentioned service coordination time is time limited, a maximum of roughly a year. Can families revisit that service, or is it a one-time only approach? And in light of the fact that families have changing and evolving needs related to their child, is there an opportunity to come back for additional coordination services?
Yes, definitely. We have tried to keep it to a new set of care coordination needs or a new diagnosis. So rather than have, families cycle through care coordination to kind of work on the same concerns or needs over and over again, and in order to make it equitable for other families seeking this type of service, that's kind of where we've left it. So we have had a couple of families who've come through a second time. We've also had families who've had some pretty intensive care coordination and come back to us with a referral for a sibling who also meets the criteria. So oftentimes we have siblings who go through at the same time, but this would be a family who went through care coordination with one child and then had some additional needs with a different child. And so is coming back through the program in that way. So yes, I mean, like I said, we do want to make it accessible to as many families as possible, given that we are a time-limited project as well. But also recognizing that some of these families, may have new issues or new needs, and being open to that re-referral. Meredith, anything to add to that?
There are a number of questions around caseload. So how many patients or families per case coordinator? What's the professional status of the care coordinators? Are they nurses, social workers, other families? And are they supported by a more fulsome hospital team, like including pediatricians and others? And do care coordinators provide medical care, for example, issues with G-tubes, etc.?
I can speak to the qualifications, and maybe Gina, I'll let you speak to sort of the numbers. But so in terms of, there's two of us that are care coordinators. I myself am a speech language pathologist by training, and have worked at the Children's Hospital pretty much for most of my career. Was working in the autism spectrum disorder clinic here, and my partner is a nurse, a registered nurse, who also worked with this population for a long time as well, with one of the developmental previous developmental clinics at the Children's Hospital. In terms of qualifications, I think that it's just having that clinical knowledge and expertise and experience. I think we both have learned a lot over our involvement with care coordination, but came into these roles already having an understanding of the systems, given the work that we had done previously. We definitely have support of administration with the Children's Hospital and with the different clinics and teams, although that that has evolved over time as well. I think initially there was lots of concerns about, are we stepping on toes? Whose role is this? That kind of thing. But I think that as we've worked with more and more families and more clinics and providers, that a lot of that has definitely smoothed out. And I also think there's definitely been a benefit for us being situated in health to be able to access some of those other professionals and expertise when it falls outside of our scope. In terms of the medical pieces, we don't really do any medical care per se. It is more that coordination. So if home care, or if there were issues with feeding tubes, for example, we would work with the family and with the clinics and the providers that are doing that directly.
Thank you. We're at the end of our time. Would you be open to, there's still a few questions left in the question box, and if I share them with you by email, would you be open to responding to them, and we can post those on our Knowledge Exchange Network as well?
Definitely. Yeah,
wonderful.
And our contact information is on the slides too, so if anyone needs to reach out to us directly, I'd be happy to respond as well.
Wonderful.
And
Thank you.
May I also just say quickly that if you go to the website link, there's some information there about the project as well as our referral form, if anybody's curious, just to see a little bit more around the structure of how we do referrals.
Brilliant. So that is the end of our time together today. Thank you to Gina, Meredith, and Genevieve for sharing your time and expertise with us. Thank you to all our members and other attendees for spending this time with us. We hope you depart with some practical knowledge to bring back to your organization. We're coming close to the end of our packed fall webinar schedule. Join us next week on December 9th at 11 a.m. when we will co-host with our partners from Solutions for Kids in Pain the webinar, the Canadian Pain Task Force, Best Practice Findings in Pediatric Pain. We're also looking for content for our Winter Spark webinar series. If you have an innovation or improvement story, you have something ready to spread or scale, please contact us at childhealthcan.ca. I'll say that again, spark@childhealthcan.ca. It's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange Network. Thanks again for joining us today. Thanks to Meredith, Gina, and Genevieve for this presentation, and to Alberta Children's Hospital for supporting our webinar program. Hopefully we'll see many of you back here next week. Bye, everyone.